Thank you, Mr. Chair, and everyone. Really an honor. I mean, and if I look nervous, I am. It's not something I do normally. Anyway, I got a pretty tough talk because I need to get a couple of points across that are not easy to understand. The treatment of obesity has just been figured out literally in the last 2 years in terms of how humans regulate weight. So it's complex. The other one is probably one of you three has biases against weight folks. In other words, 30% of individuals have biases about someone who's overweight, whether it be that it's their personality or whatever. But the fact is there's a lot of physiology that I'm going to try and cover real quick. And hopefully, there we go. All right, so let's just take a mythical person. So somebody, 48-year-old, whether they're male or female, weighs 150, and they develop low back pain, and they get placed on a medication we call prednisone, which is a steroid that will help the inflamed nerve. The problem is it tells the body to make more fat cells, so they'll gain weight. And this is a very common thing. We use it for asthma, all types of things. So over 2 months, they're on steroids. They're unable to exercise because of the back pain, and we'll say they gain 40 to 50 pounds. So now the patient is 200 pounds, and now they're a pre-diabetic. I picked 50 for a reason. That would put them right at a BMI 30. And I most respect to the prior speakers, the Asian and Hispanic population, I don't know if you know, they don't tolerate weight gain as well as Caucasians and African Americans. So it would be 50 pounds for this person, but if they're Asian or Hispanic, it'd be like 30 or 40 pounds, and they're already running into this problem. So it depends on your racial background too. So the patient recovers from the back injury and decides they want to lose weight. And so they begin a diet and exercise program. They might use a commercial program, they might use a smartphone app, and they lose 20 pounds, just 20 pounds. So they went from 200 down to 180. They're not at that 150 they used to be, but all of a sudden they found that despite their best efforts, they're not losing weight anymore. And this happened time and time again. We do this in the lab to human beings. We pay them to stay in labs. We do all this type of stuff. And I forgot to mention, in the morning I do research. I do research on how humans regulate weight and what are treatment options, everything from meds to surgery to diet. And then in the afternoon I run a clinic that sees about 100 patients that's insurance-based for obesity. The patient notices, even again, despite their best efforts, the weight slowly starts creeping up now over the next 6 months. So it turns out 20 years ago when I got in this field, we thought human beings were cued to eat. So you'd walk into a room, you'd see this delicious smelling food, and you'd say, oh, it's time to eat. It's 12 o'clock. No, that's about 20% of it. 80% of it is we are driven to eat 24/7. In other words, the human mind is wired to go seek out food all the time. And the way we regulate our food intake is that we then eat something, we release various hormones that tell us we're full, you don't need to eat anymore, and you won't eat for about 2.5 hours. So it's a little bit different from what we thought. So what happens is in this one is you take anybody and you bring their weight anywhere from 5 to 10% down, they'll unfortunately change those hormones. So what will happen is the hormone that tells you to eat will actually be higher than it's supposed to. It's not supposed to do that, but it does because, again, it's trying to get that weight back. The human brain sees weight loss as a very bad thing, and this is totally out of someone's control. It's not a personality issue or anything like that. The next thing is they won't get satiated. So in other words, there's about 6 hormones that go up and tell you, okay, I've eaten a meal, I'm full, I don't need to eat anymore. Guess what? Those levels don't go back up to the normal levels anymore. They're much lower. And if you want to look up that reference, they show these really cool graphs where you can see the levels not where it's supposed to be. Last off, and this is probably the toughest part, is you bring someone's weight down 5 to 10%, they lower their metabolism 15, 20%. In other words, totally out of proportion to the amount of weight loss. Again, the attempt to lose weight. And you talk to anybody who's lost a lot of weight, they'll say, yeah, I get cold all the time. They've lowered their core temperature, or their pulse rate has dropped, and they get lightheaded when they get up. Again, all attempts for the body to regain the weight. So it's not surprising that humans struggle with weight so much that over time, despite their best efforts, they will regain weight. Not all of them, and I'll try and give you those numbers in a second for the various types of treatments. So just so you understand where meds, where surgery, where diet and exercise have their place. Okay, so here's the good news, and I really appreciate the first speaker who showed the slide that, or was the second speaker? Yeah, second speaker, that if you can get 5% weight loss, you can save a lot of money. For me, it's more of, I'm not a money guy, I'm a numbers guy, and I want people to get healthy. So And again, this was mentioned by the chair at the very, very beginning. The biggest problem is diabetes. When you look at somebody getting heavy, diabetes just scares us to death because costs go way up at that point. And that's when all the other stuff, you know, you lose your feet, your vision. And unfortunately, I see this all day in my clinic. So if you get just 3 to 5% weight loss, that's not that much. You dramatically start to improve blood sugar control. That gets better. The risk of going on to diabetes, if you're pre-diabetic, goes down well over 50%. So everything's moving in the right direction. If you can get 5 to 10% weight loss, now, whoa, we're golden. Now you're getting blood pressure changes, cholesterol improves, everything is getting better. So the good news is you only have to get 5 to 10%, but the bad news is that's the limits of a lot of weight loss because, again, the body is fighting it. And I'll show you how you can get around that, but again, it's not easy. The really tough part is they followed these patients out a year later, and they still didn't adjust. It was as if they had just dieted. So again, not surprising. And this is, again, very recent, guidelines telling us this. So it's not like this is old stuff. This is 2013, just came out, these guidelines. Okay, so what are your options? So I'm going to break it down into diet and lifestyle changes, which includes exercise. And this applies to really anybody who's overweight or even anybody who's trying to maintain a lower weight. Then I'm going to break it down into diet, lifestyle changes, and weight loss medications because you're going to see they have to go together. And that applies to about 70 to 90% of obese patients, which is the vast majority. And then there's bariatric surgery, which applies to about probably 7% of Californians. So there are a ton of commercial programs out there, Jenny Craig, Nutrisystem, Weight Watchers, and they work. They'll clearly bring down your weight. But the tough part is their retention rate. In other words, the number of patients they have in those programs that say 26 weeks, 6 months, is about 22%. If you go out a year, it can be 6.6%. In other words, folks just can't stay in these programs for whatever reason, whether it's cost, whether it's they get bored, unclear. But again, that's unfortunately what we see in the literature, and it's pretty much what I see in my office. There's also smartphone applications. We use these all the time in the office. They actually work, but the question is, I don't know how long patients can stay on these things. Online programs, there's all these fad diets out there. I mean, you probably hear them all the time. Drink water on a full moon and things like that, but they're out there and they're pretty typical. Meal replacements are very interesting, and they have actually very good data that they produce very good weight loss over the long run. And what that is if, and I'm speaking about adults, if an adult has a problem with food intake, if you say, look, just do this protein bar or just do this protein shake or just do this like frozen TV dinner that's 250 calories for lunch every day, just don't think about it, just do that, it works. For whatever reason, just replace one meal, the weight will stay down out to 4 years. So again, they have data to back that up. But in essence, most of these diet and lifestyle programs will give you 5 to 10% weight loss. And again, not because the patient's not trying, not because the program's not good, it's because of the metabolic adaptation at that point. So that's the limits, but that's pretty good. This is, and I don't think, I do have a pointer. Okay, so if you look at this top line, this blue line, that's sibutramine. It's an old weight loss drug that's not around anymore. But you can see if you just give a weight loss drug, say, here you go, the magic bullet, don't exercise, don't diet, just like the infomercials, and you can see that their weight will come down about 6% and stay there, and at the end of the year, about 5% weight loss. If you do sibutramine with even a little brief therapy, just tell them, look, why don't you just write down everything you eat for a week? Or tell them, hey, look, why don't you go out 30 minutes, 3 days a week? That's all I want to exercise. Something like that, you can get now closer to 8% weight loss. If you do good, in other words, you have them see a dietitian, you have them learn how to exercise, you give them a weight loss medication, now you can get 13, 12, 14% weight loss. So that's how weight loss medications work. Again, they're not a magic bullet by themselves. They clearly need the other things. So the toughest part is for us physicians who are practicing is how do you combine then diet and lifestyle with weight loss medications? Because you guys know this, doctors aren't trained in this. We just now figured out how the body regulates weight. So this is just now getting taught. So that's probably the most difficult part. Okay, so let's talk about what weight loss medications are out there. So phentermine is approved for short-term use. And I'll be a little biased. I do work for the state medical board policing physicians who do inappropriate weight loss practices. This is the most commonly abused drug by physicians, unfortunately, because it can be a cash business out of the office. But if a doctor just writes a prescription for a patient and they let the patient go out and get it, it's relatively inexpensive, $10 to $20 a month max. It's only approved for 12 weeks. It's an old drug. It's been around for over 50 years. It is a stimulant. It is related to the stimulants, so it increases heart rate and blood pressure. So that's why, one of the reasons why it's short-term, again, older drug. So you can't give it to a lot of patients. You don't want to give them a heart attack, things like that. For some patients, though, it is reasonable, and again, very specific patients. Now, orlistat is a medication that's been around for close to 20 years, and it's a fat blocker. So you take it with a meal, it blocks the absorption of about a third of the fat in your diet. The problem is that, well, the human body isn't used to letting fat just run right through it, so the side effects are kind of well known in that that fat can go all the way through and you can have a little accident. So the side effects are common, and the weight loss actually isn't that good because you're not changing the food intake. You just take it and you're blocking fat. So the weight loss is probably around 2-3%. It's just relatively low, but it's incredibly safe. It's not absorbed. It's pretty much just in the gastrointestinal tract. It's a little bit pricier, about $50 to $70 a month. Okay, so because we've known about phentermine for a long time, we know the ups and the downs. It actually is a recently approved medication that's combined with a medication called topiramate. Topiramate is actually an old seizure drug that was noted to have rather phenomenal weight loss properties. So they took these two medications in lower doses, combined them to make it a single weight loss agent. So it is approved for long-term maintenance. This just got approved. I mean, we're literally last year. Now, you can look at 10% weight loss in most patients, up to 80. That's really good for weight loss medication. Unfortunately, it has significant side effects. Topiramate is sometimes called Dopamax because it makes patients feel off. Their concentration can be off. They can have fatigue. So it's a very specific medication for very specific patients. Has what's called a REMS program. So this is from the FDA. REMS stands for Risk Evaluation Management Strategy, which I'm going to cover in a second. But it basically is a way to make sure this drug is only used by the right patient, because unfortunately this drug can affect the child of a woman who's pregnant. Lorcaserin, another very recently approved medication. This is also approved for long-term usage. Now, it does not have a REMS program because it's relatively safe. And the weight loss, you can get 10% weight loss in most patients. They have something that's called a responder analysis, which is a big deal for doctors because, again, we weren't taught how to do weight loss, so this is something we've just learned the hard way. If you have a medication that, say, only half the patients lose a lot of weight and the other half don't, and remembering obesity has a lot of different causes. Maybe somebody overeats, maybe somebody doesn't exercise, maybe somebody has binge eating, whatever. So there's a chance a single medication will only fit that one person. So it turns out this hits about half the patients. They do very well. So the FDA in their wisdom said, look, if you go 3 months and you haven't lost 5%, stop the drug. That's fine. That's good. The risk is gone. They do well. So that's what they have with this program. So it improves the weight loss. You only give to the patients who are losing weight. It sounds simple, but believe it or not, this is just literally all in the last year. And again, up until now, I felt like we've been in the dark about how to treat obesity. These are two drugs that are probably going to be improved within the next year. I would be surprised if they're not. So bupropion and naltrexone is a combination of a depression drug and an opiate blocker. How does that work? So bupropion is actually used for cigarette cessation. So people who have a craving for cigarettes, that same addictive model is for food. You can crave food. Matter of fact, I do it every night about 8:30 for ice cream. And it turns out opiate blockers actually block one of the systems that tells the body to stop weight loss. So they combine two interesting medications. They'll get that 5 to 10% weight loss, but they're not approved yet. They had to do a cardiovascular safety trial to show that the issue of they do raise pulse and blood pressure about 1 or 2 beats. From what I understand, they have done that, and they are moving forward. Liraglutide is another medication that's already available, so it's used for diabetes. And earlier when I talked about when food gets into the intestine, you release a hormone that goes back to the brain, this is actually that hormone. So they've copied it, they've turned it into a drug. It turns out it helps diabetes tremendously. but it turns out it also signals satiety, so patients lose weight, and they'll lose about 5 to 10% as well. It will probably be particularly useful for prediabetes and diabetes. Lorcaserin, which I mentioned earlier, also has separate effects on diabetes as well. So those two drugs are going to be used a lot in that population. Okay, so I talked a little bit about this earlier. Medications have a very bad history. I mean, if you look at most of the drugs that we've had for obesity, most of them have been yanked. I mean, I can't believe we used to use dexamphetamine, speed, for many years for weight loss. Clearly not a good thing. So anyway, we've learned a lot. And so one is we evaluate risk. So we have the REMS program that I talked about earlier. And in essence, a patient, let's say this weight loss drug will cause a problem in a fetus. Then that patient has to go to a specialized pharmacy, and the pharmacist will say, look, are you on birth control pills, or are you not going to get pregnant? I'll give you the drug. So this is beyond the physician. So you really get that extra care to make sure the wrong patient doesn't get the drug. The responder rate, we talked about again that earlier, that if they don't lose a certain amount of weight by 3 months, stop the drug. You're fine. And that way you ensure you get a good response. Or in other words, the patients who are on it are getting a good response. All right, let's talk about surgery. Now, surgery is by far the best management for obesity, no doubt about it. And it's not because you can't eat as much. It's not because it makes you feel sick if you eat the wrong foods. It turns out it changes those hormones for satiety. So earlier I talked about when you lose weight, you will then lower your hormones to say, I'm not full anymore, even though you ate a full meal. This changes that. So it whips up those hormones to make you feel really full all the time. So it actually is a hormonal surgery. We didn't know that at the time, but it's now been figured out. And I do these fancy studies where patients come into my lab, we'll feed them a meal, and we find out what the hormones do. So that one on your left here, this is your throat coming down. You completely bypass the stomach and go right into the small intestine. So one is you slam up the hormones that tell you you're full, but you also, this part of the stomach right here releases a hormone that drives you to eat. We call it ghrelin. It's from the stomach. You take away that hormone. So the bypass is still the best bariatric surgery. We actually don't do the band much anymore. So the band is just putting a band. You put a band on the stomach. You can't eat as much. You say, okay, great, I'm full. But it turns out you just start eating more often because you're not changing the hormones that control food intake. So you do get weight loss. It's about anywhere from 10 to 20%, but it's nothing like the other procedures. The procedure that's gaining in popularity at most places is called the gastric sleeve. So when you bypass, you get a lot of nutritional problems. When you do a sleeve, you just cut that part of the extra stomach off. So you turn the stomach from a big bag into a sleeve, and you remove part of the stomach that drives a hormone that drives your weight up. So it is actually a hormonal surgery as well. But does bariatric surgery pay? This is something we look at a lot. When our clinic, we're about 66% managed care, so we have to look at costs all the time. And it's quite clear that bariatric surgery dramatically improves your weight and dramatically improves diabetes. So this should be a no-brainer. It should be good. Well, unfortunately, bariatric surgery has a lot of risks. So 1 in 200 patients will die. About 1 in 10 will get a major complication. Now, that major complication will keep them in the hospital for longer, incur more costs. So it turns out if you follow these folks out 6 years, there's no cost savings. If you did 100 patients, even though not only 10% of them had problems, that 10% raises the overall price. So it's not more expensive, it's not less, it's a wash. It's about the same. That's been really tough. So the most recent recommendation from the Journal of American Medical Association is to really think about bariatric surgery for patients with diabetes or with really bad osteoarthritis of the legs. Otherwise, all the other ones, they're just doing it because there are patients that are overweight, but they don't have medical problems. Don't push it on them. The diabetics, the ones with the medical problems, are dramatically going to get better. I hope this is understandable. Okay, so let's try and summarize this. And if you're looking at diet and lifestyle, long-term weight maintenance, I'm just going to use 2 years. The reason why I use 2 years, if you get somebody to lose weight for 2 years, you improve their diabetic risk for 5, 6, 7 years. It's called a legacy effect. Even if they regain the weight, they still have a much lower prevalence of diabetes. So again, 2 years is going to be my magic number for long-term maintenance. But with diet, lifestyle, 5% weight loss, you're looking at about 20% of those patients keeping that. So 1 out of 5 do well on their own. Unfortunately, 4 out of 5 don't. Diet, lifestyle, medications, now you improve the odds much more because you're changing some of those hormones to control weight. And so now you're looking at 50 to 70% of those patients getting 5 to 10% weight loss. And then bariatric surgery, by far the king. You know, you're taking 25% weight loss. You're talking 80% of those patients keeping that weight down. And I'll take questions, and I'm truly honored to present.
Yeah, probably the statistic that's the most interesting that you made a comment on was on the surgical procedures and how there's really no savings to the healthcare system because of the complication. So when we're thinking about policy changes, like the first presenter who said it was fairly clear that when they took sodas out that they saw a decrease in obesity. Do you see, putting surgery aside, do you see having insurance company or having the healthcare system pay for medications as a positive outcome in reducing obesity? Obviously, the first way would be exercise, diet, but is that a policy shift, do you think, that the legislature should consider at all? I'm not saying the surgery, because obviously with the numbers, to do medications at all?
I do. So for medications, for patients, and there's actually guidelines in the endocrinology literature for this. So for patients with prediabetes and diabetes, that's a group I would attack right away because you clearly can save costs there. You're going to keep them from going on to be diabetics. So in that sense, I would. And even for bariatric surgery, we're at Scripps, when we look at the managed cares, I'm thinking, you know, I really need to target the diabetics more than any other group there is.
Okay. Any questions, Senator Mining?
Thank you. This is very helpful. I guess you, in your patient community, you said you have clinics of weight loss clinics.
Correct.
Can you give an estimate of the number of patients who succeed without use of pharmaceuticals, percentage that you find pharmaceuticals to be helpful, and then the surgical option? Is there kind of some rough estimates of, in a universe of patients,
sure,
how it breaks down? Yeah.
So a typical 100 patients come in, about 10% of them are going to get bariatric surgery over the long run. It's a high percentage, but about 2/3 are going to get weight loss medications, and about 1/3 are just going to do diet exercise alone. So let's backtrack. The diet and exercise group, we're pretty close to that number. I would say maybe, although we're a center, so I have dietitians, I have exercise physiologists. So under the best case scenarios, and this was presented actually at a political meeting in Los Angeles, that if you have a center of excellence, you're going to get better results as opposed to the single doc trying to do this. But well over, I would say about 35% on just diet and exercise do well, as opposed to that 20%. So about 1/3, a little over 1/3 do really well. On the medications, we're probably right around that 80% mark. It's fairly high, only because I have the medication, but I also have the other things.
And then it may be too early to tell, but with the Affordable Care Act implementation, are you partnering with any employers who are referring employees to work with you, where the employee is covered through their insurance to get the benefit of your clinic?
I think I just saw my first patient about a week ago for that. So yeah, you're right. In San Diego, we have these, really, Qualcomm, big companies. And yes, we're starting to see these patients from companies I'd never known about, just for what you said. So they're partnered up. They're coming in and said, look, you got to get your weight down, because for all they showed, the presenteeism, the absenteeism, all that other stuff that comes along with it. So correct, it's just now starting to happen.
Great, thank you.
Thank you. Any other questions?